Good morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from the USA, Professor Nicholas Theodore. Professor Nicholas is the director of the Johns Hopkins Neurosurgical Spine Center and is a nationally recognized expert in brain and spinal cord injury, minimally invasive spine injuries, and robotics. He earned a medical degree at the Georgetown University School of Medicine and completed both a residency in neurosurgery and fellowship in spine surgery at the Barrow Neurological Institute. As an award-winning teacher and researcher, he has written or co-authored 30 book chapters, over 180 peer-reviewed journal articles, and is a co-holder of 10 patents for medical devices and procedures. His research focuses on trauma, spinal cord injuries, robotics, and developing an understanding of the genetic and molecular basis of spinal diseases. He treats patients with a variety of spinal disorders, including trauma, Chiari malformations, spinal deformities, degenerative spinal conditions, and spinal cord tumors. We are extremely grateful to him to accept our invitation to be a speaker at our webinars, and today he will be talking about engineering the future of spine surgery. The speaker for the second session of today is our very honorable guest from Korea, Professor Jun Ho Chung. He is from the Department of Neurosurgery at the Medical Research Institute, Pohang Stroke and Spine Hospital. He was a former associate professor at the Cerebrovascular and Endovascular Surgery Stroke Center, Department of Neurosurgery at the Gangnam Severance Hospital, Yonsei University, Seoul. He was a former visiting scholar for the Neuroendovascular Surgery at the Department of Neurological Surgery at the Rush University Medical Center, Illinois, and is a noted author with several publications, various peer-reviewed journals, and he was also the editor of the Journal of Cerebrovascular and Endovascular Neurosurgery. We are extremely grateful to him for accepting our invitation to be a speaker at our webinars, and today we will be talking about surgical treatment of intracerebral hematomas. The chair for the first session of today is our distinguished faculty from the United Kingdom, Professor Andreas Dimitriadis. Professor Dimitriadis is a consultant neurosurgeon at the NHS Lothian and Edinburgh University Hospitals. He was the National Clinical Lead and Chairman of the Scottish Acquired Brain Injury Network. He is the immediate past president of the European Association of Neurosurgical Societies and is an expert in dealing with complex spine and spinal cord diseases as well as brain pathologies. He is a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Nicholas Theodore. The chair for the second session of today's webinar is our honorable guest from Singapore, Professor Vincent Ng. Professor Vincent is a consultant neurosurgeon at the Mount Elizabeth Medical Center, Singapore. He was the former head of Department of Neurosurgery at the National Neuroscience Institute, Singapore. He was also the co-director of the Endovascular Center and director of Joint Neurovascular Service at the NNI, and he is a member of the CNS, ANS, and he is an expert at the minimally invasive surgery for brain and spinal cord diseases. We are extremely grateful to him for accepting an invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President of Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Singh from Malaysia is my co-host for today. And with that introduction, if Professor Andreas is there. Okay.
Hello to everyone. It is my genuine privilege to introduce our distinguished guest speaker today. We're living in a remarkable era where the boundaries between medicine and technology are not just blurring, but they are being completely redefined. Nowhere is this fusion more impactful than in the precise and high-stakes world of spinal surgery, and there are very few individuals on the planet better suited to guide us through this evolution than our speaker today. He's not just a neurosurgeon, he's a visionary who operates at the very intersection of human biology and advanced engineering. Dr. Nick Theodore is professor of neurosurgery, orthopedic surgery, and biomedical engineering at Johns Hopkins University. This unique academic trifecta perfectly encapsulates his approach with a deep respect for the art of surgery, powered by a relentless drive for engineering innovation. Nick's work is pioneering. He's been at the forefront of developing robotic-assisted spine surgery, using artificial intelligence to improve surgical outcomes, and creating novel technologies to make procedures safer, less invasive, more effective for our patients. He doesn't just use the tools of the future, he's actively engineering them for us. So to talk about engineering the future of spinal surgery, we're not getting a theoretical overview. We're actually getting a first-hand account from one of the architects themselves. So with a very warm welcome, let's hear from Professor Nick Theodore. Dear Nick, the floor is yours.
Thank you very much, and good morning to everybody. Good morning, everybody, and thank you for the opportunity to speak to you all. For the next few minutes, we're going to talk about the last few years in my lab and some things that we've been working on, really at the intersection between engineering and spine surgery. And I think those two specialties go hand in hand together, and we'll sort of bring you up on some of the things that we've been working on, and I think some of the things that we'll be seeing in the future. These are my disclosures, some of which are relevant to this talk. So when I look back at my career, this was Dr. Joseph Ransohoff, who was this very storied neurosurgeon at NYU. And this is my favorite quote, that really no self-respecting neurosurgeon would ever focus their careers on spinal surgery. And I think at that time, it was felt that spine surgery was a lesser interest and not really fitting of a neurosurgeon who should be operating on the brain. I think nothing could be farther from the truth. When we look at engineering and surgery, especially spine surgery and neurosurgery, we realize from the very beginning that we are very technologically wedded. We need and have benefited tremendously from advances in engineering. So this on the left-hand side is William Bovie, the originator of the Bovie electrocautery device. And on the right side is Harvey Cushing, really the father of neurosurgery in the United States, utilizing the Bovie to stop bleeding. And think about that for one moment. Without that device, really surgery as we know it would be much different, right? How can we operate without getting hemostasis? This is James Greenwood, who was a neurosurgeon in Houston, developed the bipolar electrocautery device. And again, imagine doing surgery now without instruments to stop bleeding. These are fundamental engineering advances that brought us in, allowed us to do what we do in surgery much safer. This is Jose Delgado, and just as a fun aside, he was a professor at Yale, and he had the idea of putting an electrode into the brain of a bull and then pushing a button and having the electrical activity delivered to the bull's brain so that the bull would not attack his assistant. Notice that he did not come out there by himself, but he had his assistant out there. But this really was the start of engineering in neurosurgery when it came to stimulation of the brain. And now we have brain stimulation, spinal cord stimulation, etc. Dick Berglund, and this is in the 1970s in the United States, thought that neurosurgery really wasn't going to go anywhere because we didn't really have any advances in the field. I really think nothing could be farther from the truth. When we look at neurosurgery and we look at where we have gone in the last 100 years, we realize that as a specialty in neurosurgery, especially in spine surgery in particular, there are hundreds and hundreds of patents that have been issued, and it shows you the activity in this field, which has really exploded. I think a turning point in my career for my esteemed colleagues in Japan was Professor Watanabe's description of image-guided neurosurgery. This, for me, changed everything. As a young resident, we had the ability to touch the brain and to see on a screen exactly where we were. This ability to take a patient and marry it to a medical image changed our field forever. But there's not a brain operation now done in any developed country without the assistance of this technology, which really helps us be more safe and accurate for the delivery of care in our patients. This is from about almost 20 years ago when I started utilizing image guidance in the spine. And, again, we were using K-wires, very careful, but we had the ability to percutaneously put hardware in. One thing I noticed, though, at that time was that our attention was diverted. We weren't looking at the patient, we were looking at the screen. And I think that this, for me, was a moment of interest because I realized that maybe we can do better at what we do. So in spine surgery, why do we want to use image guidance? Why would we want to use image guidance? Well, what we want at the end of the day is high accuracy and high procedure. We want to hit the target every time. And when we look at this, and when we look at our ability to put screws in, for instance, this is a series that was published from Johns Hopkins, my own institution. About 9% of the time, the screws breach and are not where we want them to go. And most of the time, thankfully, that's not a problem. But about 1%, 1.5% of the time, we have to reposition the screws, and almost 1% of the time, we're taking patients back to move hardware. When we look at our ability to do this, when we talk about freehand, our overall accuracy by hand is about 68%. When we start using X-ray, we get up into the 80s. And when we use image guidance, we get into the 90s. And I would argue that we can even do better than that now with the advent of robotics. This is what we want to avoid, right? We want to avoid this tragedy. And the tragedy is one misplaced screw, which can have devastating consequences. And yet, even though the demonstrated need for this is there, and even though it has been shown time and time again that this technology is helpful, the fact is that still we've had only about 15 to 20% of people start using this technology. And part of that has to do with workflow. And if it's not made into our workflow, people aren't going to use the technology. I would argue that as spine surgeons, we're still lagging behind our cranial colleagues, and we're a little slow to adopt technology, but I think the time is now for that to happen. We're at a very special time right now in surgery. We've had we've had advances in imaging, advances in surgical techniques, and then we have the advent of surgical robotics. So image-guided surgery now has been around for almost 40 years, has changed our field. Surgical robotics with Da Vinci and others have there. But I think we're in a very special time now where we have the ability to meld all three of these into the field of image-guided surgical robotics. What are we asking for? Well, we want to help automate that procedure, which is what we do commonly. This is Dr. Fyodorov in Russia in 1980. And when he was doing refractive surgery, he said, "Why do I have to go from one operating room to the next operating room? Why can't the patient come to me?" And the operating room was set up such that he would actually operate on a patient, fix the problem, and then the patient would rotate and the next patient would come in. So imagine this, being able to take a procedure and do thousands of them. He became world famous for this, and his technique and accuracy were unprecedented at the time because of this ability to help, with his workflow. The first robot in spine surgery really was born out of Johns Hopkins. This is my colleague, Dr. Russ Taylor. This is the RoboDoc, and it was a robot to help core the femoral shaft. And this was the advent. This then later came the Da Vinci, which gave our ability for the general surgeons and neurosurgeons in some tumor cases to operate within the abdomen or chest at a distance from the patient. We've got some robotic radiation surgery now with the CyberKnife. Our orthopedic colleagues are using robotics now for hip and knee surgery, which has been transformative for them. And in China, apparently, robots are going to put the massage therapists out of business too. So this is the recent video here. Imagine being able to go in and get a massage from a robot. I think the advent of robotics now in medicine is here and not going anywhere. It's here to stay for sure. And right now we're in what we all call task autonomy, which is the robot helps the surgeon. It's not doing the surgery by itself. Well, what do we want? We want to be able to have reproducible accuracy. We want to hit that target at every time, just like this robot. So if I use the analogy of American motorsport racing and NASCAR, this is 1964. The car comes in. They come out to fix the car. You can see they're doing some work here. He says, "Hey, look at my fender is broken. Can you fix that?" And they said, "Sure, we'll go ahead and fix that for you." And this took several minutes to be able to go in, they check the fender again, and then the car goes back. And this is where I learned to do spine surgery. This is 1984. And if you look at this, again, we have open palpation of the pedicle. We're feeling the medial edge of the pedicle, done open with direct visualization. And this was an art. It was an art form. But if we look at 2016, we look at NASCAR and it's a much different picture, right? So now, in the course of about 13 seconds, we're able to change all four tires, fill the car up with gas, change all the fluids, and the car is out. And I would argue that we are now able to do this reproducibly in spine surgery. So this is now doing an MIS TLIF, putting 4 screws in about 4 minutes with 99% accuracy, sub-millimeter accuracy, utilizing robotic assistance. The whole concept of this came to me over 20 years ago when we started thinking about, well, what would a robot look like and what would a robot do? How would we design this? And my first thought was the robot would be doing the surgery by itself. Unfortunately, that's not going to be the case because in the United States, we have the FDA and they're not going to allow autonomous surgery. But why would we even want robotics? Well, patients are looking for less invasive surgery. They want small incisions, faster recovery time, less disruption of tissues. We as surgeons want to reduce our radiation exposure, and we want to do the procedure accurately, and we want to be able to plan what we do. From a radiation perspective, shooting fluoroscopy during surgery is hazardous to our health. Patient incurs a risk of radiation every time they get out of operation, but for the surgeon, there's a 5-time increase of cancer death because of our lifetime exposure to radiation. Even if you wear a thyroid shield and radiation gear, it only protects about 66% of the exposed body. This is me throwing my lead away a few years ago because I'm no longer shooting X-ray when I'm in the room. So the concept of a robot in spine surgery came to me. This is when I was at the Barrow in 2000, taking an off-the-shelf robotic arm and being able to marry that to image guidance. The question was, could we target the pedicle? This is the setup again 25 years ago. This is Neil Crawford, a biomedical engineer and my co-inventor of the Excelsius robot. And designing this on wheels so that it could come into the room so that we could actually do surgery is a daunting task. And this took several years, many years of development. This was our first working prototype of the Excelsius robot with 6 axes of freedom, developed by a surgeon and engineer on wheels, able to target the pedicle utilizing images obtained in surgery or before surgery. The other, technical feature was that it had real-time image guidance. So you would actually touch the patient, and if the patient moved, the robot would move with it. So this is in 2012. This was our first foray into this. And I would tell you that we shot an O-arm. This is a cadaver, putting in K-wires. And what I learned back in 2012 was that we could hit this target perfectly. The robot would follow the directions and be able to take us exactly where we needed to go. In 2017, this was commercialized by Globus Medical. And now every day I'm using this device, as are thousands of cases in the United States and the world with real-time image guidance. This was our first case on October 4th, 2017. You can see a lot of people in the room. And again, being able to place screws in just several minutes with sub-millimeter accuracy changes the paradigm of what we do. So just a few cases of things that we've done recently. This was a woman who had osteomyelitis and a fixed kyphotic deformity. You can see this with cord draped over this. Again, being able to put screws in very small pedicles. This was a individual, almost 400 pounds, who had fallen from a vehicle. And look at this, so chance fracture in the setting of ankylosing spondylitis with a large BMI. And he was also a Jehovah's Witness, meaning we cannot transfuse any blood. But literally, we're able to do that case in about 45 minutes with minimal blood loss. And that really changes the paradigm. We're now doing hybrid surgery where we'll make a skin incision and then percutaneously place screws through the fascia. This was a cancer patient, so we don't need to open everything up. We're able to do one incision, but but do a tumor decompression separation surgery and fixate the patient without significant blood loss. This was a trauma case that we did in the middle of the night. It was a police officer who was involved in a high-speed motor vehicle accident. Actually had a fracture dislocation at the apex of a known scoliosis, untreated, asymptomatic, but it came in with a fracture dislocation at T12L1. Here you can see the burst fracture with offset here. And again, being able to do this in a trauma case is really where all the skill comes together. We're able to, in the middle of the night, get in one spin with intraoperative imaging and be able to correct the deformity and also fixate the spine to decompress the spinal cord. Now we're starting to do things that are a little off the beaten track. This is a patient with a hemangioma of the bone. These are obviously very vascular lesions, atypical in this case in that it's broken through the cortex and is causing spinal cord compression. These have significant blood loss. There's many different ways to treat these, most of which will involve multiple stages with embolization and then also fixation and resection. We did something a little bit different in this case, where we planned robotically to put screws in, but I also plan to cannulate the pedicle of the affected body at T10. And with that, my endovascular colleague was able to embolize the tumor with Onyx. And we looked at that, we shot a few x-rays and did that in real time. The neat thing was that the tumor's embolized, we stabilized the spine, one incision, minimal blood loss, and symptomatic improvement, which has been stable now over the past 5 years, and really a different way. Again, the ability to do things with enabling technology has really changed our field. We're doing cervical cases now as well. This is this body surfer who came in with a bilateral hangman's fracture at C2, but also with significant stenosis and cord compression. The elegant thing here was to be able to do a direct repair of the fracture. So you can see here we've planned with the robot to drill right down the pars and be able to fixate the spine, sparing C1, C2, and being able to decompress the spinal cord at the same time. So this has been sort of an exciting way to do things. We're also now doing cranial applications with deep brain stimulation with the robot as well. What has it shown us? Well, our accuracy has improved for sure. We are now able to not just say we're in the pedicle, but we are able to say, where did we plan the screw? Where was it placed? And then where did it go? So when we first started doing this is our first series that we published actually in the Chinese Medical Journal, that's a part of the World Federation. And you can see in D and E and G, there's a little bit of an offset. We're off a little bit, not in the canal, but off. And the reason for that was from a bit of skiving of the drill. Once we saw that, we were able to correct our drilling technique. This happens infrequently now, but the reality is we're continuing to figure out a new way to do surgery. We're now being able to actually do volumetric analysis. So our accuracy has improved even further into the 99 plus range from an accuracy standpoint. When we look at our colleagues in orthopedic surgery, when we look out several years, they have found that utilizing the robot has been very helpful in their practice. That has helped them increase their accuracy at 5 years because those patients are continuing to do better than those that didn't have a robot. And that has to do with the precise jigging. I think what we'll find in spine surgery is that hopefully our adjacent level disease will go down over time as well. So we looked at our first series. How does this work? So we looked at our first 28 cases and compared it to 56 controls. We found that the robotic group had much less blood loss. They stayed shorter because less tissue disruption. There was really no difference in complications, but what we found was that the length of the procedure decreased significantly over time to the point where we are now reliably doing a single and two-level fusion in less than 2 hours. So that really changes the paradigm for us in spine surgery, because again, you can see when we first started, the time was significant, but again, with practice makes perfect. So we've looked at this further when we started looking at how much does it take, and we've learned that proficiency requires about 20 cases. At 60 cases, mastery is reached. By 60 cases, you know you're familiar with the system, the team is familiar, and you're able to get through things very quickly. What's next? If you think about this, this is a video from the meat packing industry, and robots are being used now in meat packing to carve meat, cut meat, take it off the bone, which is very, uh, labor intensive. So I've taken this to the lab, and the question is, can we use a robot to help us with bone cutting? Can we do osteotomies and laminectomies with the robot? And the answer is yes. We absolutely can plan for a robot to do these cuts. And the FDA will be a little worried about that to begin with, but I think at some point in the not too distant future, robots are going to be helping us with all of that. And then ultimately to the point of autonomous surgery. So this is Axel Krieger, who's in our lab at Johns Hopkins, and has the ability to use machine vision. So when the robot can actually see, it can help us with that. The other thing we're looking at now is how do we decrease radiation further? This is a paradigm that we just published looking at MRI, which can be converted to CT. So what you're seeing here on the left is not a real CT, but it's a CT that has been reconstructed by MRI. So this is a cadaveric specimen. This is a synthetic CT. On the left is a CT scan made from an MRI, and on the right is a real CT. What you see on the right is a little bit more information, but on the left, it's enough information, in fact, more than enough to accurately instrument the spine. So we took those images, and on one side of a cadaver, we used real CT scan, and the other side, we used a synthetic CT. And we found out the accuracy was 99% for both sides. So what I think we'll see in the not too distant future is the ability to do surgery without needing a CT scan, to be able to do surgery with just an MRI scan converted into a CT. Augmented reality is coming as well. Lots of new things in our engineering lab. We're able to now automatically plan pedicle screws utilizing a machine learning algorithm, so that instead of you placing on the robotic screen where you want the screw to go, this can be done automatically based on your preferences. And we're also looking at artificial intelligence to be able to take us through understanding which patients will benefit from surgery. And I think that the whole field of automated accuracy and artificial intelligence is just happening. We're now looking also at the workflow in the operating room. How do we understand that we make that workflow better so that we can cut down the time of the procedure and make the procedure go more smoothly for the patient? We're looking at cognitive load. What does that mean for the surgeon? What we found is the usage of robotics decreases that cognitive load because it's one less thing you have to worry about. So the last few minutes, I want to talk about our work in spinal cord injury. The happiest lab is our spinal cord injury lab at Johns Hopkins. And the whole idea was building implants for acute spinal cord injury. How do we make us better? And one of the things I've become very interested in is perfusion of the spinal cord and managing that perfusion. We know that hypotension is bad. We understand in the brain for sure, we treat cerebral perfusion pressure, which is mean arterial pressure minus ICP. We can do that in the spine too. By placing a lumbar drain, we're able to measure cerebrospinal fluid pressure. And I would argue that in trauma, this is probably very beneficial. This really, this concept struck me when I looked at our colleagues in vascular surgery, because when they cross-clamped the aorta back in the day, about 40% of the patients would be paralyzed because of ischemia to the spinal cord. One of those things they did to mitigate that was drainage of spinal fluid. So if you look at the green line here, this was in a porcine model. When we elevated mean arterial pressure after spinal cord injury and drained spinal fluid, those animals had persistently elevated perfusion, better perfusion than just elevating the blood pressure. When we elevate the blood pressure alone, we really don't know what we're doing. I think the literature is now pointing to the fact that treating spinal cord perfusion pressure really will become the standard of care. So we did a randomized study a few years ago in Phoenix and other places. We enrolled only about 11 patients, but we were able to show that we could increase spinal cord perfusion pressure safely. And it also allowed us to decrease the mean arterial pressure because we were treating a known endpoint with utilizing spinal cord perfusion and drainage of spinal fluid. What we're working on in the lab right now on the right here is a catheter, which not only can drain, but it monitors pressure in real time and allows us to monitor temperature and also with fiber optics biomarkers of spinal cord injury. We've also been looking at ultrasound. These are actually vascular images of the spinal cord. Look at the resolution we can get with ultrasound. The problem is we don't have an ultrasound device that we can actually leave in the patient to measure perfusion after spinal cord, and that's something that we've been working on. Elastography is a part of ultrasound that I've become interested in as well. It measures the elastic tension, and we find after spinal cord injury, because of swelling, that elastography increases and the heat map increases. This all has to do with stretch on the spinal cord. So I started thinking about my patients with tethered spinal cord. This is my last patient that I did an open detethering on. These operations are very tedious operations. The question is, can we do better? And once again, going back to Japan, Professor Coco Bun came up with this idea of vertebral column shortening, taking out part of the T12 vertebral body to shorten the column, and in doing so, taking the tension off the spinal cord. And I will tell you that now we've had a series of about 80 patients that have had this done. These patients have small pedicles, but you can see we've shortened the column. On the left, you see the spinal cord under stretch. On the right, you see it after shortening. We published this paper a couple of years ago in neurosurgery. We showed significant improvement in pain, motor function, sensory function in these patients who've had this operation. We started looking at ultrasound. This is before shortening. Look at the excursion of the spinal cord after surgery. And I think the fact is that we are now able to measure that tension in the spinal cord with ultrasound in the operating room. So this paper was just published in Science Communications, where we looked at a few of our patients prior to shortening in the operating room, and then as we shorten the vertebral column, what we found is a significant decrease in tension on the spinal cord. We reproduced this in a cadaver, and this is sort of interesting, but as you can see, as you pull on the spinal cord, you see the heat map going up. So now we're able to actually measure that stretch and tethered cord. Again, this was published in Nature Communications Medicine, but really never been done before, measuring elastic properties of the spinal cord. But my problem was in trauma, and I wanted to see if we could actually measure perfusion in trauma. One of the problems with spinal cord injury, acute spinal cord injury, is, again, we have no biomarker, we have no measurement of understanding what's happening at the spinal cord from a perfusion standpoint. And I will tell you that this is a difficult problem. So we've spent a long time building up our ability to image the spinal cord. We have a pig model, and we ended up with our team building the first micro ultrasound array, the music device, which allows us to put this device in onto the spinal cord after injury. It's attached to a small metal rail on pedicle screws and allows us to measure perfusion in real time. This has never been done before. So we've got FDA sort of breakthrough device. We have robust data in the animal showing that we can actually measure blood flow at the penumbra and at the injury site and above and below that to understand what's happening with perfusion so that we can actually tailor our therapy for the patient in the acute phase after spinal cord injury. One of the problems with ultrasound, though, is that you need to use microbubbles many times, which are injectable agents that help, like contrast with our resolution. In our lab, though, Dennis Radkovich published a paper recently. We're now able to get very good results without the usage of microbubbles. We also, have built devices that allow this device. You see the blue ultrasound device would attach to a pedicle screw in surgery, and then allow it to be removed when the time comes. So ultimately, now we're looking at this. Now we're able to measure in vivo hematoma expansion and pulsation of the spinal cord and blood flow post-injury. So we have an injured animal in the ICU. We're able to measure for several days. And the idea of all of this is to put together a system with spinal fluid drainage and measurement of perfusion where we can figure out autoregulation. Ultimately, what I'd like to do is understand when it's time to stop treating the patient. When has autoregulation been restored? When do we need to? Because right now we don't have any idea how long that is. Is it 3 days? Is it 5 days? Is it 7 days? But this will help inform us and hopefully elevate the care of our patients with acute spinal cord injury. We're also using this in tumors. We're looking at this because with ultrasound, focused ultrasound, we can disrupt the blood spinal cord barrier, which allows us then to deliver chemotherapy to the spinal cord. This is being done in the brain now every day, and we're now starting to do this in our animal model in the spinal cord. And lastly, I wanted to talk about biomarkers. Part of the problem with spinal cord injury is that we don't have, we can have an MRI, we have imaging, we have a clinical examination. We don't have any other biomarkers to help us. There are blood biomarkers, some of which are okay, but what we've done in the lab was come up with a cell-free DNA genomic blood marker. So we just published this just a couple of months ago in Journal of Clinical Investigation, which is the very first proteomic assay blood test for spinal cord injury. And what we found is that it is highly sensitive and specific. And not only that, but here's the ASIA levels. You can see it stratifies based on ASIA level down to controls. And we're able to actually predict 6-month outcomes in these patients with a blood test. That's going to change the way we do surgery because we will now have a blood test that will help guide our therapy. Are we doing okay? How severe is this injury? So we're doing external validation right now. So ultimately, I think the take-home message for me today is that the intersection between engineering and spine surgery is a very busy intersection. We have many, many projects going on. And I think technology is part of our lives. And I think it's exciting to see with the advent of machine learning, artificial intelligence, robotics, how we smartly and ethically evaluate these technologies and bring them into the operating room, into the clinic to care for our patients. This is our happiest team in Baltimore, which is a very large team. I welcome you all to come to visit us there or in my new lab, which will be opening up in Arizona. And with that, we'd like to thank everybody this morning for their time and attention and thank the organizers for the ability to address everybody.
Well, thank you. Thank you very much, Professor Theodore Nicholas. That was like tour de force, wonderful innovations, and like we're all looking forward to these technologies to come into life so that one day we can really change the outcome of spinal cord injuries and brain injuries also. We can open this for discussion. We can invite comments from the panelists. Yes, Dr. Liu, any comments from you?
Thanks, Prof, for fascinating future direction in spine surgery. I have 3 basic questions, Professor. In your experience regarding optical image-guided system and electromagnetic, which one would be the future? Because we still find optical may not be as good, especially in the mobile segment of the spine, where we have difficulty to place the reference point. My second question, Professor, do you think that in the future, the system will be able to identify nervous tissue and avoid them rather than identify bone and to target them? My third question, Professor, regarding current AI, would it be in the future when we scan a single level vertebral body, the system will be able to tell us which vertebral body, because even in this era, wrong levels are still very prevalent. Thank you, Professor.
Well, I'm going to start with that one first. I think that, wrong level surgery is really a huge problem. And I think absolutely with higher level image guidance and imaging techniques, that will be eliminated because, especially now we're registering by image, by vertebral body. So we're going to be able to identify the target of choice, and that will be co-registered with the patient. So I think while it will probably never be completely go away, I think we'll get even better with that for sure with the new algorithms. The second question will go backwards with nervous tissue, 100%. So when I showed you the video with machine vision, so if the computer's able to see if we're doing some sort of open surgery, if we're cutting bone, and we have some idea of what's happening, that will give us feedback. Other technologies like ultrasound, electrical impedance will be able for us to distinguish between bone and nervous tissue. So if a drill or a cutting device goes through bone and hits the dura, it will stop. So the answer is yes. Right now, we do that by hand, and we're very good at what we do. But I would argue that we can do better. And I think part of the problem with us today is that because, at least in this country, in the United States, we have much fewer time with the residents, and they don't have as much time to learn. So all the skills that we practice for so many years has to be collapsed into a short period of time. So they will rely on enabling technology to help them through their careers. So yes, that will happen. And I think distinguishing nervous tissue can be done today. It's just not incorporated, but that will be very helpful. And then the first question you asked was between optical and electromagnetic. So this is a great question, and I'm going to try to answer it in 30 seconds because I could talk about it for an hour. We have gone down this road of optical image guidance because that's been the easiest way to get there. Is there a better way? In my heart, I believe there is. Electromagnetics came and went. There are problems with electromagnetic because of interference and because of other things that may get in the way of proper signal. But I still believe, and this has been a conundrum in spine surgery, that there will be something, and it might be a combination of optical and electromagnetic, something that gives us a different way to register the imaging to the patient. Because right now, where optical has gotten to be very good, but you are line of sight and you know just from the factor of where the reference array is, definitely gives me pause every day. I think about that. We just haven't got a solution to that yet.
Thank you.
It will happen. Yeah, it will happen.
Thank you.
We're all looking forward to that day. I hope it happens soon. We can invite other panelists also. Professor Vincent, would you like to say something?
Thank you, Professor Doda. That was really a tour de force presentation, and I'm very much inspired by the future of spine technology. I want to ask a little bit about, you mentioned in your slide about a chasm that we tend to struggle with. Maybe you want to share that with us a little bit on how you overcome that bit for spine technology.
Sure. So I think, we all want to make things easier. Everybody on this call has got a phone, and we're now wedded to these digital devices. And, we also want to be able to do things at a better rate. I think that chasm happened, by the way, because when image guidance first came out on the spine, is those of you who are as my age, you're all younger than I am, but I think if you recall, it was very complicated. It took a lot of steps. We had to do point-to-point registration. Many spine surgeons said, not going to do that. It takes too long, and it's not going to be good. So because of that, we lost a whole generation of surgeons that just didn't have the patience for the technology. It has gotten very fast and very good now. So older people are starting to revisit. The younger group, my residents and trainees, all adopters, 100%. You touch it once, you use it, you're an adopter. The second part of the chasm has to do with cost, and certainly in developing countries, it's expensive technology. There's no doubt about that, and it's not rolled out yet. Over time, as with anything else, that technology will spread, and the cost will come down, and the adoption will become. Now, I've seen hundreds of thousands of cases now done robotically in spine surgery. That number is only going to continue to increase. It's not going to go backwards. And I think, again, as newer trainees come out, they're going to be pushing us old guys to make sure that we're using that technology for the patient.
Thank you.
Mr. Junho Chang, would you like to ask something?
No, not really. It's a totally different field, but I'd like those kind of, innovation can be, accepted by our field, neuroendovascular field. of course.
So endovascular is a phenomenal, another example. There's some beautiful robotics being done now in endovascular surgery. And with my robotic platform, we're doing brain surgery too. We're putting in deep brain electrodes. We're doing things targeting for hematomas, et cetera. So, as much as I say I'm not we're a separate specialty in endovascular, we're all benefiting from the technology. And I think, with all these advanced techniques, robotics in particular, I think they're gonna eke into all of neurosurgery, brain, endovascular, and spine.
Yeah, I believe so.
Well, thank you, Professor Nicholas Theodore, for taking us through these various innovations that is being developed in your lab, and we are looking forward to this into daily clinical practice. Thank you very
Thank
much.
you very much.
So I'll give this podium over to Professor Vincent, who will say a short introduction, and invite Professor Junho Chung for his lecture.
Good day to everybody. Thank you for coming into the ACNS webinar. Today we have Professor Chung from Korea, who's going to talk to us about surgical management of intracerebral hemorrhage. We all know that historically, based on even since our residency training, that to prove that surgical management and taking out a blood clot was initially fought with a lot of questions. Is there really equipoise? Is there really real benefits? Until very recently, and then the technology with all the invention that we just talk about has moved rapidly over the last few years. We'll now invite Professor Chung to share with us all about the surgical management of intracerebral hemorrhage. Passing over to you, Professor Chung.
Okay, thank you. Hi, I'm Junho Chung. I'm going to talk about surgical approaches to ICH today, and there's nothing to disclose related to this presentation. Before moving into ICH surgery, let me briefly introduce my new institution, because I have just moved to another hospital on this March, which is Pohang Stroke and Spine Hospital, one of 4 specialized centers for stroke and cerebrovascular care in Korea. We provide comprehensive treatment from emergency management to advanced surgical interventions with a 24/7 neurovascular team. Last year, we performed around 1,000 brain operations. Of course, we do both microsurgery and endovascular surgery for intracranial aneurysms. And we had 119 cases of IA thrombectomy last year, about 10 cases per month. So our institution also functions as a certified clinical research center capable of conducting medical device trials and multi-center studies. Okay, with this background, let me now turn to today's topic, intracerebral hemorrhage. Okay. ICH remains one of the most devastating types of a stroke, with a mortality rate exceeding 40%. Despite decades of research, purely medical therapy has provided only limited impact on long-term functional outcomes. The primary goals of surgery in ICH are straightforward. We want to reduce the mass effect, control ICP, and prevent further secondary injury caused by blood toxicity and inflammation. However, most of the early randomized surgical trials were largely neutral in terms of functional benefit. This historical disappointment has shaped our clinical practice for years. But more recently, with the advent of minimally invasive techniques, there's a renewed hope that surgery can truly alter the natural history of ICH in selected patients. The evolution of surgical strategy in ICH is quite instructive. Conventional craniotomy has long been used, and while it can certainly be life-saving, it has not consistently translated into functional recovery. Another important strategy is decompressive craniectomy. This approach focuses on structural volume release and is sometimes the only option in deep hemorrhages with malignant swelling. And minimally invasive surgery has gained momentum, particularly with landmarks trial, such as MISTY and ENRICH. The concept here is targeted hematoma removal with less collateral tissue injury. More refined endoscopic and parafascicular approaches, these techniques promise a balance between adequate clot evacuation and preservation of critical white matter tracts. In ICH surgery, our attention focuses on the location and the volume. When the volume is very large, we need to perform an urgent decompressive craniectomy and hematoma removal to control ICP and save patient life. On the other hand, when hematoma volume is small, medical management alone is usually sufficient. The real dilemma comes with the borderline cases. These are the patients where we hesitate and where clinical decision making becomes difficult. That is why every large trial on ICH surgery has used slightly different inclusion criteria, because deciding on the cutoff hematoma volume is always a matter of debate. And location is also important. For eloquent areas, the goal is to minimize new deficits. In deep sites like the basal ganglia or thalamus, we focus on preserving white matter tracts. Hence, the role of transcercal or catheter-based approaches are so important. And when hydrocephalus develops, EVD alone can sometimes stabilize the patient and prevent rapid deterioration. So overall, the surgical strategy is not just about removing blood, but about carefully balancing location, function, and risk. In addition, several background factors also affect ICP. First, brain atrophy sometimes provides reserve space, but also means a poor recovery potential. Second, brain edema or swelling, sometimes predictable or sometimes unpredictable, can raise ICP. And finally, pre-existing damaged tissue from prior trauma, previous strokes, or encephalopathy makes the brain less tolerant to further injury. There are 3 recent key trials have shaped our current understanding and practice. First, the MISTY-3 trial tested catheter-based evacuation combined with thrombolysis. The overall result was neutral. However, a strong signal was observed when the residual clot volume was reduced to less than 50 milliliters, highlighting the importance of surgical end goals. Next, the SWITCH trial investigated decompressive craniectomy for deep ICH. The study showed a borderline reduction in death and severe disability. Finally, the ENRICH trial was a turning point. In patients with lobar ICH, minimally invasive evacuation resulted in a significant improvement in functional outcomes compared with medical management alone. In contrast, anterior basal ganglia cases did not show benefit, underlying the importance of patient selection. Altogether, these trials provide a framework for how we now think about surgical decision making in ICH. The ENRICH trial provides us with several important practical lessons. First, benefit was clear only in lobar ICH, 30 to 8 milliliters, treated within 24 hours, and in patients with good premorbid function. Second, outcomes depended on achieving a residual clot of 15 milliliters within 24 hours, showing that surgical goals must be measurable. Third, safety was reassuring, with 30-day mortality reduced to 9.3% in the surgical arm, compared with 18% in the control arm. And the implication is very clear. A minimally invasive surgery can benefit patients with ICH, but only when applied to the right patient at the right time and with the right technique. They use the BrainPath device for minimally invasive surgery. This slide illustrates the basic principle of paravascular surgery. The key idea is that we enter through a natural circus, and in doing so, we may transect only some of the short association fibers that connect nearby cortical regions. These fibers are less functionally critical. In contrast, the long projection fibers, the ones that carry essential motor, sensory, and language information, are preserved because the surgical corridor is oriented parallel to them, not across them. By following this principle, we can safely reach the intraaxial lesion while minimizing damage to eloquent cortex and preserving neurological function. So, in essence, this technique accepts minimal, controlled disruption of less critical fibers in order to protect the major functional pathway. The brain path consists of an obturator and a sheath. The obturator creates a corridor by gently separating tissue, and the sheath keeps that corridor open. With different size available, it allows a minimally disruptive transcircle access while preserving critical fibers and function. And here you see brain path in action. The obturator opens the circle corridor, and the sheath gives direct visualization of the clot while protecting white matter. Compared to traditional retractors, this reduces parenchymal injury and helps preserve function. On the left, you see the step-by-step concept of minimally invasive evacuation. Planning the circle corridor, inserting the obturator, advancing the sheath, and removing the clot. On the right are the matching intro photos of a critical entry, sheath placement, clot visualization, and the evacuated cavity. Of course, translating InReach into everyday practice has not been straightforward. A recent international survey published in this year highlighted this gap. After InReach, about half of clinicians reported changing their practice, but only a minority, around 18%, actually used the InReach device. Barriers like cost, availability, and interspecialty debate remain major issues. Interestingly, about a quarter still recommend MIS for basal ganglia ICH despite negative result in that subgroup. So overall, InReach has influenced the practice, but real-world use is still heterogeneous and lacks consensus. For cerebellar hemorrhage, it is simple and clear. If the patient shows neurological deterioration, brainstem compression, hydrocephalus, or if the clot is larger than 3 centimeters, immediate surgery is mandatory for life-saving. In my own practice, I approached the ICH with a direct cortisectomy, taking the shortest path to the clot. But over the past decade, I've shifted to a transcircle approach using natural corridors to minimize cortical injury and preserve function. As I told you that the InReach trial did not demonstrate a benefit for basal ganglia hemorrhages. However, in our own study, we specifically looked at lateral type basal ganglia ICH when the hematoma volume was between 20 and 50 cubic centimeters. We performed frameless navigation guided catheter drainage, typically within the first 24 hours. This approach allowed us to safely assess and evacuate the clot in selected patient where open surgery would have been too invasive. When we compared these patients with those who received best medical treatment alone, functional outcomes were significantly better in the surgical group. Hospital stay was also reduced, reflecting faster recovery and fewer complications. So, based on our data for borderline volume, lateral type basal ganglia hemorrhages, we strongly advocate for early catheterization as an active treatment strategy. In case of aneurysmal SAH, accompanied by a borderline volume ICH, particularly with ruptured ACOM aneurysms, our practice has been to secure the aneurysm first with coiling and then evacuate the ICH using catheterization. This approach allows us to address both problems effectively without adding the morbidity of large craniotomy. One important point is that most ICHs from ACOM rupture occur on the opposite side of the dominant A1. This makes simultaneous surgical clipping and clot evacuation very challenging. In these situations, endovascular coiling combined with catheter-based hematoma evacuation offers a practical and safe alternative. How about hemorrhagic transformation after MCA infarction? In patient with parenchymal hemorrhage type 2, we initially tried hematoma evacuation together with decompressive craniectomy. But in our study, this approach, hematoma evacuation, did not improve functional outcome or mortality. In fact, it increased the rate of reoperation. So currently, for parenchymal hemorrhage type 2 after MCA infarction, I perform decompressed craniectomy alone without hematoma evacuation. And in terms of technique, we have previously proposed a standardized craniotomy method about 15 years ago. By identifying 5 keyholes on the skull, the surgeon can reliably decompress the entire MCA territory, regardless of patient head size or who performs the surgery. This has clearly improved outcomes and survival in our experience. Behind these personal experiences, the evidence tells us that minimally invasive surgery can improve outcomes, but only in carefully selected lobar hemorrhages, treated early and effectively. For deep ICH, catheter drainage or decompression may aid survival. For cerebellar hemorrhage, the message is clear. And for the future, we need institutional protocols, quality metrics like residual clot volume, and more randomized trials with standardized training to bring these techniques into wider practice. So surgery in ICH is not one size fits all. It must be tailored to the right patient at the right time and with the right technique. If we can achieve this balance, then surgical intervention will no longer be viewed as a merely life-saving, but as a true pathway to functional recovery for our patient. Thank you for your attention.
Thank you, Professor Chung. I would invite the participants to ask any questions on the Q&A, but I'll start off with the first question, Professor. You mentioned about the frameless placement of the catheter for the deep basal ganglia hematoma. Just wondering whether do you do that with any thrombolytics like RTPA or urokinase and all that, or is just a direct placement with perhaps aspiration?
We aspirate little bit in intraoperative, and then after that, we tried natural drain first, and then if it doesn't come out enough, we use TPA because we don't have urokinase anymore in Korea.
Sure.
Yes.
Thank you. You did mention a little bit, but I was just wondering, is looking for a CT spot sign for these kind of ICH part of your institution protocol? And if it is positive, does it change the way you manage these clots, for example, in the deep or the lobar hemorrhages?
Yes. Usually, we take CT angiography together, and then of course, it is important sign, the spot sign. So when we see the spot sign without any vascular abnormality, we just wait for like a 24 hours because it's a kind of moderate volume of ICH, which can be managed by only medical therapy. So we just treat the patient with the medically first, and then after 24 hours, if the hematoma is enough to evacuate, we just put the catheter afterward.
I see. There's a question online, something about by Dr. Harshad Parekh about what is your view of panventricular bleed? How do you manage?
That means only a ventricular hemorrhage without parenchymal hemorrhage.
I presume it's one of these grade 4 IVH where the whole ventricles are all kicked. Do you use vein path, or you just put in the urokinase the catheter with RTPA subsequently? How do you manage?
Like before we have endoscope, so endoscope surgery is quite useful when the ventricles are full of the hematoma. You can just suck out the hematoma and irrigate, during the procedure. But these days we don't have it, so we just put the thicker catheter, which is about 12 French catheter inside, and then bilaterally, and use TPA like both side, one another. Yes, one after another.
Thank you very much. I would like to open the floor to Dr. Raja and Dr. Liu as well.
Yes, first of all, thank you, Dr. Junho Chen, for this wonderful lecture. As you mentioned, all the trials and all, but I would like to mention that the ENRICH trial, though it was a success, in practice, actual practice, you will never get a patient who is fit for that trial because all elderly, frail patients were excluded from this trial, and also, as you rightly mentioned, the anterior basal ganglia hematomas were also excluded. And but the importance of that trial is that is the only positive trial so far we have achieved in intracerebral hematoma. And the impact of that trial is that the ongoing trial, which is the mind controlled randomized trial, came to a halt. They stopped this trial midway because of the results of the enriched trial. And but the patients who were already enrolled, they took a subsequent analysis and they found that there was no outcome between either surgically managed or medically managed. It came out in JAMA in the first week of this month. So perhaps we are yet to find out the right patient who will have benefit with minimal invasive treatment of intracerebral hematoma. Nevertheless, it was a wonderful presentation and we really enjoyed a lot. Thank you very much.
Okay, thank you.
I think we can hear the concluding remarks. Dr. Liu doesn't have any questions, he said.
There's still one more question on Q&A.
Oh, on the Q&A, okay.
Yeah. Do you have different protocols of management in cases of eloquent and non-eloquent areas of hemorrhage?
Oh, well, not protocol, but my conclusion is that it depends on the patient, right? So the eloquent area, we try not to make new deficits, right? So according to those values, so we can decide whether or not treat the patient by surgery. So we don't have a protocol for between eloquent or non-eloquent, but we have some kind of the value to evaluate the patient.
Mr. Chong, you also mentioned a little bit about the your switch from direct cholecystectomy to transsulcal approach. Through transsulcal, we know that that's where quite a lot of in the subarachnoid space, quite a lot of the vessels. Do you find that there is a higher risk of vessel bleeding through that particular approach rather than just directly going into the brain parenchyma?
Oh, not really, because you know, usually the most of surgery, microsurgery I perform is aneurysm surgery, right?
Yes.
So we are used to dissect arachnoid membrane, right?
Yes.
So for me, it's not that difficult, and then it's a quite. I felt that the patient outcome seems better. So yeah.
One addition to that is that when you go to the sulcus, there is a sulcus, and between two sulcus there is a trough. So the projection fibers mainly arise from the top of these areas, and very few projection fibers from the base. That is why I may be having a better outcome. We can conclude this, Prof. Vincent.
Yes,
Please.
thank you. I think we should close the session. Thanks.
So thank you very much, Professor Junho Chung, for this wonderful presentation. Now I'd like to close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Theodore Nicholas as well as Professor Junho Chung, and the Chair, Professor Vincent Eng, for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. I'd like to mention that we are broadcasting this on WeChat, YouTube, and Zoom, and as of now, we have around 660 people who have joined us live for this event. And also special thanks to my co-host Liu Bun Seng for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.